Hello, and welcome to the McKnight's webinar, COVID-19 and Flu Season, How Simple Changes to Sharing Patient Data Can Yield Better Health Outcomes. I'm McKnight's Long-Term Care News Senior Editor, Liza Berger, and I'll be your moderator today. Our session's featured speakers are Brenda Hopkins, Chief Health Information Officer of J2 Cloud Services, and Michelle Darnell, Chief Commercial Officer of Secure Exchange Solutions. I will introduce them more formally soon, but first some housekeeping matters. Today's slides are available for download. Just click on the Handouts tab on the left side of your screen to find a PDF of the slide deck to print out. If you are having any audio problems with this broadcast, please first check the volume control on your device, as this is the most common cause of hearing problems. Please note that the sound is coming from the computer speakers. We will have time for a Q&A session near the end of the presentation. If you have any questions for any of our speakers, please feel free to type them out and submit them to us starting now. Regarding continuing education. This educational offering has been reviewed by the National Continuing Education Review Service of the National Association of Long-Term Care Administrator Boards. It has been approved for 1 clock hour. However, you need to stay tuned to this event in its entirety during the original broadcast to receive a certificate. You can track CE requirements through the course completion tracker, which is accessed through the last icon in the area below the open webinar panel. Once you have achieved 50 viewing minutes, a View Certificate button will display, and the required viewing duration will have a green checkbox. You can then view or save your certificate. A copy will also be emailed to you afterwards. We'd like to note that this program is made possible by support from Consensus, a brand of J2 Cloud Services. Learn more about Consensus at consensus.com. Finally, this session will be archived and available on demand shortly after the live broadcast. You can access it again, or others can experience it for the first time simply by going to the registration page to enter the studio. The URL is mcknights.com/120820webinar. Now to our presenters. Brenda Hopkins provides strategy for J2 Cloud Services in the area of healthcare interoperability, where she is focused on open data exchange of healthcare information inside and outside of the EHR and using open platforms and tools such as APIs as a means of sharing. Trained as a pediatric neonatal transport nurse, she has also held leadership positions at GE Healthcare, Kaiser Permanente, and Adventus Health Purchasing, building, implementing, and scaling large enterprise EHRs and ancillary solutions with a strong focus on meeting clinical, revenue, safety, and quality goals in value-based payment models and care delivery programs. Michelle Darnell is co-founder and chief commercial officer of Secure Exchange Solutions, a neutral and trusted cloud-based healthcare information exchange network. Her career spans 2 decades of healthcare IT software executive management with commercial health insurance, healthcare, life sciences, and government experience. Prior to Secure Exchange Solutions, she has held executive level strategy, sales, operational, and advisory roles at New Era of Networks, Bridge Forward, Hybrid4, Campus Search, and numerous emerging growth software SaaS companies in the health information technology space. So Brenda and Michelle, I think our listeners are very interested in learning about how the sharing of patient data can help improve the experience of the flu and COVID-19 this year. You're going to fill us in on that today, is that correct?
Correct, Liza. Thank you for the introduction. This is Brenda Hopkins, and I wanted to thank you all for your important time today. Good morning, good afternoon. As Liza said, I'm the Chief Health Information Officer for J2 Global. Michelle and I are going to share with you today how to help in building your infrastructure for your organization to safely and efficiently share patient information neutrally between applications and organizations during transitions of care and changes in health events. So you as leaders and members in the long-term care community have a balance of pressing operational, financial, and regulatory issues and finding technology that enables these workflows and business needs. You live daily between both the virtual and the physical world. According to a recent MedPAC report, 40% of the Medicare beneficiaries are discharged from the hospital to post-acute facilities. With the large aging population, the U.S. health systems face growing pressure to streamline transitions and optimize patient outcomes while controlling costs. So fee for value, reducing readmission rates, recruiting and retaining caregivers, and improving workflows are at the top of most people's minds in the long-term care space, as you well know. What we're talking about today is the unique happenings with the cold and flu season and the omnipresent COVID virus that is with us today. And it's bringing especially challenging times for us as we're delivering care, with the heightened risk and the unexpected consequences for residents and employees of long-term care facilities transmitted by newly admitted residents and by healthcare personnel and by visitors. So preventing transmission of the viruses and other infectious agents within the healthcare setting, including the long-term care facilities, requires a multifaceted approach that includes, at a clinical level, influenza vaccination and testing, COVID testing, and soon to come vaccine, and infection prevention and control measures and antiviral treatments. To support those overarching clinical operational needs that we have as part of treating patients, we need dependable, reliable, present data. So immediate patient data upon admission and transfer of care should be available to those healthcare personnel, especially for infected patients. So we're going to share with you ways to optimize your existing technology, infrastructure, and share with you new ways to receive lab and patient data during the important transitions to alert you and your staff to COVID or flu in order to best provide the best treatment and safe care in the most timely way. So expecting health data to flow securely and ubiquitously without a technology-neutral infrastructure is kind of like expecting Amazon delivery to arrive when there's no roads or bridges. So the digital infrastructure that we're going to talk about today, which some of it may be very familiar and you're using today, or some of it you're starting to move into, is as important as the physical pieces of it. So in today's healthcare system, delivery processes involve numerous interfaces and patient handoffs among multiple healthcare practitioners with varying levels of education and occupational training. During, for example, the course of a 4-day hospital stay, a patient might interact with 50 different employees, including physicians, nurses, technicians, and others. So effective clinical practice thus involves many instances where critical information must be accurately communicated. Team collaboration is essential. When healthcare professionals are not communicating effectively, patient safety is at risk for several reasons. There's a lack of critical information, there's misinterpretation of information, there's unclear orders over the telephone, or overlooked changes in status. COVID-19 has brought up the issue of fragmented health information again, making interoperability of health data paramount. Connecting the health story of individuals holds valuable clues to the diagnosis and the treatment, and supports organizations to keep residents safe, to keep employees safe, and from the virus, and also to support eligibility for performance payments from the government. So data today is still locked in individual EMR systems after a patient visit. On the end side, the payer too have a large portion of the data through claims and encounter data that flow to them during the billing process. So as an example, a patient's journey from ambulatory care to urgent care and acute care in an episode of COVID-19 has tons of important health information generated in a very short span. And seamless access to this information about a patient across the care continuum is the solution to a better care coordination. So to realize the real value of interoperability, all other care systems along the care continuum, such as skilled nursing facilities, home care, primary care providers, they all must be connected. COVID-19 has brought about a transition in the way medicine is practiced across the world. Physicians and clinicians were reluctant to go virtual and are now opting into it. And so there are troves of important data like positive COVID results, signs and symptoms, sitting in siloed EHRs, and now telehealth or telemedicine services across different health systems and care settings across the country. And these troves of patient data, when they're harnessed in an automated, real-time, neutral fashion, can be used in health systems for patient care and patient safety, but also for reporting for states and federal governments to predict surges, and also for reimbursement programs that governments have for timely and safe delivery of COVID care. And it also helps systems prepare and manage for severity-adjusted programs and predict other findings. So COVID's demonstrated the need to go virtual and seamless and to provide improved care to patients. And we all know that already. It's just the COVID virus has really forced what we've already known and done into a different light that's required a different level of immediacy and certainly a different level of data need. So as more systems continue to remodel their businesses around these needs, interoperability, which is the sharing of data, will become more of a lifeline to better care coordination across the care continuum. This slide is a slide from a class report in the Post-Acute Care 2020 report. And what you're looking at is health system connectivity. And the first line shows fax or e-fax as the way information is still shared between systems. And in this report this year, much to many's probably not surprised, fax is still used often between systems that don't communicate natively or easily. And so fax is one of the very few ubiquitous technologies ever created. Wherever you go in the world, fax is fax. In addition, even today, fax is still one of the most secure methods of transferring information, which is why it's still at the heart of document-based workflows in a whole range of regulated industries such as healthcare. So fax has been around for a century. It's still going strong. However, the standalone fax machine, with its manual processes and its analog lines, its expensive ink, the paper and consumables, is becoming a thing of the past. And so today organizations are moving toward digital fax service. So CloudFax offers best deployment to enable fast and easy paperless faxing across the entire organization and can communicate with not only all of the systems that are up on the slide here, but any other because it's agnostic of vendor and neutral in digital infrastructure. CloudFax can get rid of, as an offering in the way of sharing data, can get rid of equipment and running costs associated not only with the standalone fax machine, which has its vulnerabilities with paper, but also on-premise fax servers. You can also reduce your costs by avoiding telephony-related phone lines and IT burden on supporting on-prem fax infrastructure. And cloud-based fax solutions are fast, efficient, secure, and easy to use. So the best fax service when you're thinking of something as important as patient data is that there's a network of globally diverse data centers to add resilience and availability and business continuity into the offering. And what you'll have when you're doing your budgeting is a movement from CapEx to OpEx within the on-demand cloud service. So for many organizations, fax is a mission-critical part of everyday business. As I've mentioned, it's ubiquitous, it's familiar. and the same level of security and performance and enterprise integration that you need in an enterprise system, CloudFax can deliver both on the front end and also on the back end for your systems. It also, of course, needs to meet strict security needs for healthcare in the way of HIPAA and perhaps even HITRUST and data protection, and meet your compliance and risk programs. And what you'll find again in CloudFax, and FACS that's familiar and been around a while, is that it's a modernizing way to use the workflows that you've already trained on and are comfortable with in your business process, but now you can integrate a fax document distribution in any of your applications and also organize that patient information in a much more meaningful way. Michelle is going to introduce another form of sharing of patient information, which is called direct secure messaging. Michelle?
Thanks, Brenda. So as Brenda described, cloud faxing in the digital information exchange space and the need for us to further build out our major highway systems. Direct secure messaging is one of those major highway systems for exchanging information. And as Brenda pointed out, the exchange of this information, especially given flu season, COVID, and just in general, is critical to patient care. And this concept called direct secure messaging is a very important piece of that, because it allows for secure exchange of information of all types about patient care across organizational boundaries. And although we all expect that with Amazon, it is, and we expect that in our healthcare system, that's not always the case. Direct secure messaging is designed to be very simple and secure, and it's scalable, and it can be used by really all stakeholders in the healthcare continuum, including long-term post-acute care, facilities that have electronic medical record systems, and also facilities that have minimal capability. So it is scalable across a wide spectrum. Direct is a national standard for secure health care communications. It's part of the certified electronic medical record program and requirements. It's been suggested under 21st Century Cures Act that every MPI provider have a direct account, and on the diagram shows a provider A connecting to provider B with a secure message between. I think it often is it's riding on common internet standards for security, which is really important, because that's what helps us, move toward that Amazon model. But it's not really just standard regular email. It is HIPAA compliant. It's very cost effective, and most importantly, it is very easy to integrate into your existing capital investments, whether those are electronic medical record systems, lab systems, patient portals, document management systems. It's easy to integrate into existing workflows. So the reason this is important is that there really still are roadblocks in sharing information. We spent many years on, moving out those roadblocks, but there are still challenges with health information exchange occurring. And as Brenda indicated, with COVID and with the flu season, it's even more important to unlock those roadblocks and to unlock silos of data. Just some recent stats. Still, there are a large percentage of hospitals that report that they are have difficulty sharing clinical information electronically with providers, and that would include long-term post-acute care providers outside of their systems. The cost of exchange is often still high, and the time to develop that exchange is long. And proprietary interfaces have generally cost a range from $5,000 to $20,000 due to lack of standardization. And although there are some wonderful community type efforts around querying for information, in many cases that takes a long time to develop and deploy. And so direct secure messaging is a wonderful standardized method, easy to use, quick to get on board, and it can quickly adapt to new needs for sharing information, whether that's transitions of care or lab results or other types of documentation that might be useful to your patients that are in the facility. Next one. So the community, the direct trust community, is a large community with a large footprint. It is a large nationwide community of connected providers, more than 2.4 million participants, most of which are providers in this secure, trusted exchange community. And it touches all stakeholders across healthcare, many of which are providers of different types. And it includes over 250,000 organizations across the country. So in this large connected cloud of trusted connections, there are acute care hospitals, integrated delivery networks, providers of all types, primary care providers, specialty providers, long-term care, post-acute care, behavioral health, senior living, home care, health plans, and also patients. And what's really interesting is that as this model for exchange has evolved, there is access to an ever-growing nationwide directory that indicates where you can reach providers at the point that they want to be reached, whether that's in their EMR system or on the mobile device or through a web browser type application. This directory generally provides access to where to find a provider. So that's an important part of it, is this overarching community. There are many different examples on how providers are using this type of messaging, ranging from transitions of care, discharge notices and alerts, referral summaries, which is critical to long-term care, post-acute care, referral notes, patient alerts, specific requirements under quality programs. And there's emerging use around the sharing of lab results, patient messaging, medical documentation, proof of medical necessity, and other, of course, especially in this time, critical public health reporting, and that is very needed, especially in this time. So a few use cases, if we drill down into a couple of use cases on how direct messaging is being used in the long-term post-acute care market. This marketplace is still very heavy, traditional paper-based environment, and facilities generally receive thousands of documents that are supporting transitions of care, orders, lab reports, medication lists. And as patients, Brenda noted that 40% of patients that are discharged from hospitals receive post-acute care. So there's there's continued opportunity still to improve the quality, safety, and efficiency of care as patients really move through the continuum of care from the acute to post-acute care and long-term care facilities. When we used functions such as direct secure messaging embedded in some of the solutions that are already in place at long-term post-acute care facilities, it can really simplify the communications and help with this transitions of care and care coordination. The facility can be getting more information electronically about their patients and residents from all parties, hospitals, physicians, hospice, and other care partners. And the information can be delivered electronically and securely, often into their existing environment, their electronic medical record environment. It's also possible that on the back of a referral that the facility might receive electronically, they can receive a full continuity of care document that's generally a history of either the patient encounter or their full medical history can be sent directly to the facility from the hospital, and it can the facility can also send outbound those continuity of care documents to other practitioners or to hospitals where their patients may be discharged to, or also to insurance and payer-related organizations. In the end, this helps with improved quality of care and just in general better patient follow-up, and really lowers the risk of preventable readmissions. So on the back of this highway, next slide, Brenda. On the back of this highway, there are a number, as I mentioned, a number of use cases that are important to providers, and alerting has become even more important, especially this year with COVID-19. Alerting is a way that sounds basic, but it is really a way for providers and for your facility to monitor patients, to monitor high-risk patients, and really understand what's happening with their admissions and discharges and movement through the care continuum. It's an ability really to keep in the know about patients. There are different types of alerts. Basic admission, discharge, transfer alerts, alerts that come as a result of a particular lab event or a diagnosis code that's part of an admission, discharge, transfer, alerts that can be used around gaps in care. So there are a variety of alerts. If you use one of the highway systems that we're talking about, many parties are able to participate and get alerts about their patients. So a use case example around alerting in post-acute care management, there are a number of them. It felt like one that might be important to this community is where integrated ADT alerting is used to monitor, to really trigger and kick off a whole end-to-end post-acute care program that manages patients throughout the post-acute care cycle for a period of 90 days. And so in this use case, a patient is admitted to a hospital, and the post-acute care management team are notified that Jane Doe was admitted to the hospital, and that really kicks off a whole series of events that help to navigate the care transitions for Jane Doe, and helping her providers along the way to focus on delivering better care. So this is important and continues over a 90-day period of time, which is key really to managing risk about the patient. The alerting can support also transitions that might be required around authorization and utilization management for post-acute care, home health and home infusion, and then also to share information alerts around the coordination of needs and the coaching of patients as they heal at home. So the overarching results for in this particular use case are that the patient really receives optimal patient outcomes, that they are given the right path of care, the right length of stay, and the right care of home. And the alerting process focuses on really how to, deliver key information that helps support all of those goals and results, with the overall benefits that it's really just a whole optimized post-acute care transition.
So it's a lot of information I know we're sharing, but one of the things that with the alerts that's meaningful, and as I know as a nurse as well, is that we really don't work sitting at a desk, and information doesn't come into our inbox in a predictable way, and then we can do our care. We're up and down, taking care of patients, doing transitions of care, transfers. So what Michelle's talking about in the alert is just that. It's a notification about a high-risk patient. And, what I really want to share with you about the alert technology, if you will, is that hospitals already have this technology, this capability within their systems already, which you receive patients from. So an ADT alert is called Admission Discharge Transfer Alert, can be sent to you via a direct message that Michelle was talking about, or it can be sent by a cloud fax, or it can be sent more meaningfully as deeply in interoperability as an HL7 message. But when CMS put this, there are hospitals who receive government funding, critical access hospitals, behavioral hospitals, and acute care hospitals send an ADT. They're under the conditions of participation. There's a program now that'll have deadline into next year. The ADT notification can be sent, and there is no specific standard. So your technology doesn't have to mirror what hospital's technology is. It can be sent via cloud fax, direct message, or an HL7 message. And all this information, by the way, I know I'm very aware we're giving you a lot of information that should have a lot of questions behind it, and we're more than happy to follow up with you on the technical details. But the first myth, if you will, that I want to debunk about an ADT notification that's meaningful in the post-acute environment is that it's not difficult to get that, and it can be easily done. It's not a major implementation. The other thing that Michelle was talking about in the way of other tunnels or highways or communities, they're called health information exchanges, some of them regional, some of them statewide. And this notifications, if your organization participates in something called an HIE, if that's at all familiar to you, you can receive an ADT message through that as well. And as we know, more than 99% of the hospitals today have EHR systems, so most of the ADT transactions are minimal effort. The ADT was fundamentally the first module actually you would really implement in a larger enterprise system. So it's already there, it's been well vetted, and it's very well used to track transitions of care. And, we're talking today about this convergence of the influenza and COVID-19 virus and the importance of data and the stress that it's caused on our systems, on our staff, on ourselves, on our families. But a global pandemic really is exactly the moment when you want to try to bring things like this forward in the hope of data sharing more meaningfully. This technology has been around for a while, and it's now been very well vetted. And, you know, people like Michelle and myself in this space can help put together the pieces for you so that, again, the hope is to get the right information at the right time for the right reason for the right patient, right? We all know that that's the goal of what we try to do. And these different technologies with minimal nuancing can help in that endeavor. Michelle, you want to talk about
yeah. Sure.
Yeah, go ahead.
Sure. And I was just going to add to that is that Brenda raises some really important points about the alerting and HIEs. There are a number of ways that your facility can get access to these types of alerts, whether that's through an HIE or direct through services that might be offered through hospitals that are referring patients to your facilities, or through some of the care coordination networks. The most important thing is, I think, to realize that the capability is there, and to ensure, especially in this time, that your facility is signed up into one of those circles so that you can ensure that you are notified about these key events. And one of the other use cases that we're seeing specifically around alerting is that it is a critical part of referral management, and we know that referral is key to long-term care facilities, post-acute care facilities, and home care. And in this use case, providers are really able to get those referrals, which include the alert, electronically. And it generally, in this case, the receivers are typically receiving these in an EHR message center, but that is not a requirement in all cases. As Brenda mentioned, you could also receive these through a cloud fax environment or an HL7 interface, or even a report that's delivered electronically to a secure direct address, web type application. But through this process, and the flow that you could think about that's in place is that a home health referral order might be pushed out for a particular patient. That really triggers a full continuity of care. That's basically a clinical summary of the patient that's sent to the EMR. The intake teams, or the care transition intake team at the facility, would be working on the referral and placing the patient in the perfect and preferred place. This particular use case also looks up through that nationwide directory that I mentioned and finds the primary care provider related to the patient, to also notify the primary care provider that the patient has had some movement and a referral, and is finally used to close the event at the end, basically to, once the patient's been matched to post-acute care or home care, to automatically return information back to the referral site and the patient status to the ordering physician. So those are a lot of critical parties along the way that are kept in the loop, really, and this helps facilitate the whole referral management process, and really all starts with that, basic ADT alert.
great. Again, we realize this is a lot of information. The deck is going to be available to you, and phone number and email as well. But we have some time to take some questions if you have any now for follow-up, and we can send information as well.
Well, thank you so much, Brenda and Michelle. That was really informative and interesting. So yes, as you mentioned, it's question and answer time, so please don't hesitate to send your questions. We've got a few already, so let's get started. First question, where does the patient communication fit in? Do they sign all the care over to the providers?
Well, I'll take a part of this, and Michelle, I'm also interested in what your thoughts are. So patient communication fits in when you're admitted to a hospital, okay? Part of the where of the alerts that go out come from you. You come in and, when you go through an admission process, which some of us may have personally or have done with our family members, and they ask you a series of questions. They ask you for your primary care provider, and it's at that time that you are able to tell them within your existing care team who else needs to receive alerts about your movement, and we're calling it transitions in a health system. So the patient communication, the where and the what of the alerts are all come from when a patient sits down and provides information at the time of an admission. And that information, whether you're saying, please, I'm coming out of, XYZ skilled nursing facility, please have all of my transition information sent to them. If their primary care or specialty providers need to be communicated to, that is being provided by the patient. So I think that's a part of it. I'm not sure if the question wants more than that, but I will tell you the dictate of the routing of the who and the what of where the alerts go all come from a patient.
Okay.
Michelle, do you have anything else, or maybe looking at that question?
I think there, as I listened to the question, I actually thought of a number of different intersection points with the patient. And our goal in the industry is to improve patient access really over the next 2 years and further. And patient access today is already available and kind of overlapping with some of these technologies that we've talked about during this call. And one point specifically around ADT notifications is many cases facilities are getting reports about admission and discharges of their patients or members, and they are reaching out proactively to contact the patient to ensure that the patient gets back into the office in a timely way or into the setting in a more proactive versus reactive approach. And so although the alert is not being accessed by the patient in that case, the patient is being engaged sooner and faster, and that's kind of critical to our overarching goals. The other thing we see is that some of these approaches that we see are being tied to various patient-related applications, whether those are a patient portal that a patient might go to request a copy of their medical record, or a copy of that record be delivered to their doctor, or a patient application that is more of a wellness app where the patient's information needs to be transmitted and delivered down to the traditional EMR that's in place in the patient's care. Increased volume of telehealth. So there is a overlapping of like the patient, where the patient asked for information to be downloaded, to be directed, or the patient's had a telehealth scenario where their information then needs to go to the specialist or the hospital that's going to see them, or the situation where the facility gets an alert and they reach out and engage the patient faster, which is also kind of key to improving the care management, care coordination of the patient.
Okay. Very good. Another question for you. My facility does not have an electronic health record. What steps do I need to take to use direct message or cloud fax to receive alerts?
Michelle, you want to start with that one for direct?
Sure. So direct is available through a health information service provider. In many cases, if you are able to get it through your electronic health record system provider, if you don't have an electronic health record system, you can contact a health information service provider. It's kind of like an internet service provider, but for healthcare. There's a listing of those that you can find on an organization called Direct Trust on their website. But if you query health information service provider, you would find parties that can offer a direct address. And that generally is made available in very easy to get going ways, similar to perhaps some of the secure email packages that you've used in the past. It is a easy approach to get onboarded and provisioned and started with exchanging and accessing the nationwide directory that continues to build. And
with CloudFax, and just to add on as well, I don't know what the best way. I would encourage you maybe to start maybe with McKnight if they have guidance on, CloudFax providers that are available to you. Part of this presentation today, Consensus and eFax Corporate, of course, is a CloudFax provider that can help. But a Google search as well might help to, again, find the criteria that I started in the presentation with, that you really want a highly redundant, very secure, reliable, 5 nines, no downtime company that's invested heavily in infrastructure. There may be fax providers out there, but you want an enterprise quality fax service that is proficient in the cloud, that has integration capabilities, that is in healthcare, that understands and speaks your language. And certainly eFax is one of those, but perhaps, again, McKnight can help in linking you with some people as well. And through that process, what's most important, whether you're looking for direct or for cloud fax, is that as part of any technology purchase, you know yourself what's important to you in your budget and into your quality, safety, security needs before you go out and send out information to understand what you might need in your digital infrastructure.
All right. We have another, thank you for that. We have another question regarding patient consent. Do you have to consent for the patients to participate in direct messages?
Michelle?
Should I take that thing? Yes, so the patient's participation, generally the participation of, when the patient enters the facility, they sign their HIPAA consent form that indicates that information can be shared. That is a consent to share, whether it's via fax, paper, secure email, direct messaging, or cloud fax. And so that is generally handled through the consent process for HIPAA information share at the facility.
Okay. Any other thoughts on that one?
Nope.
Okay, great. Another question, how do alerts help in managing our COVID-19 and flu populations?
So what's going to happen when you have an alert, as we talked about on when you're admitted to the hospital and your diagnosis is COVID, that information is going, or your discharge diagnosis is COVID. Maybe you don't know what you have, which is the case many times when you're admitted, but you're discharged with COVID. That information, again, because it's an alert and the quickness of the ability, how do I say this? It's triggered automatically. There doesn't need to be human intervention. When you, as a patient, leave the hospital, so does that diagnosis to your receiving facility. So how it helps in the way of COVID is a couple ways, COVID and flu, is that you are having a more timely understanding of a patient coming into you. You're not waiting for all of the discharge instructions and all the rest of the documentation that's part of the patient profile. You know that you're going to be receiving, in this case, as an example, a COVID patient, and you're going to be able to prepare in the quickest way possible wherever you're housing your COVID patients. Additionally, as I know the long-term care community knows, the ability to have data about your COVID patients and how you're treating them, this is an additional metadata area that you can put into your reporting so that you can show how well you're managing your COVID patients. You've invested in understanding patients that are coming in to protect your not only your patients but also your staff. And there are reimbursement programs now of how well infection rates are being controlled by management of COVID. So what the ADT and what the alerting mechanism does is really give you the best possible chance to prepare and provide the best care.
Okay. Very good information. We have just kind of a smaller question. You had mentioned a system that has over 250,000 organizations participating. Did you mention what that system is called?
So let me just clarify. That is so you can think about this like a community. It's a large, trusted community of 2.4 million predominantly providers who are part of 250,000 organizations for this direct type exchange. So it's a growing, so it's not one organization, it's really sort of the patchwork of organizations across our nation that are all able to communicate using this standardized approach called direct secure messaging. So the 250,000 organizations are, major IDNs, hospitals, acute care hospitals, critical access hospitals, psychiatric hospitals, providers, specialists, long-term care. So it's those are the organizations that are part of this large trust community.
All right.
That are using direct secure messaging.
Okay. All right. Very good. Thank you for that. Okay, we have time for a couple more questions. Here's one on paper, not using paper anymore. Does opening our world to more than paper for patient information, make a difference for our business, patients, and referral relationships?
It'll only help if we want to take even the thought of downtime, the need to have more than one place to have patient information. But I'll take it from a market perspective. Your organizations will be much more competitive as technology continues to proliferate through healthcare. everyone needs to get on board. And where you get on board, you have variability. You can start, if you are using a fax machine, you can go to digital, cloud fax. That's an easy jump. And then think about direct messaging. You can think about these health information exchanges like Carequality and Commonwealth as well. I would encourage this audience to embrace technology and embrace digital information as part of quality, safety, and competitiveness for your organizations. We've already jumped over security hurdles for information that really now CIOs are trying to move to the cloud. Cloud strategy is prevalent. Cloud is a wonderful way to manage your applications because of the on-demand nature. I mentioned you don't have to worry about servers. You pay as you go in many cases. And it helps in an already stressed budgeting environment, and I understand that deeply with skilled nursing. So it's baby steps, and there are digital paths forward, but certainly I encourage you all to take steps wherever those feel comfortable to help in passing information and data between systems and to help you in your reporting needs that are at the very least cumbersome for many people. Sometimes having your information digitally can help your staff as well.
That's great. That's a wonderful kind of almost way to wind things up, or round things out here. But let me just try to fit one more question in here. It's kind of related to what you said, and maybe our listeners might be interested. So we're a system, here's a question, we're a system that still uses a lot of paper faxes. Does that mean that hospitals won't use us for referrals? Does it actually eliminate kind of those types of relationships?
Michelle, do you have a thought on
that? So I think that it doesn't eliminate those types of relationships, but I think that to Brenda's point, as more and more organizations, I mean, those relationships are business, those are business-to-business relationships, but as organizations look to move faster, become more competitive, increase their, quality metrics, and be able to improve patient outcomes, that the movement toward electronic exchange is, even if it's a small step, kind of gets you there. And the expectations just in general are to move in that direction in the marketplace.
Mm-hmm.
And
okay.
I would just say,
go ahead.
Oh, I was just going to add quickly, sometimes you do the best you can do with where you are. And there's no kind of keeping up with the Joneses wouldn't be encouraged if they're buying the best of the new and what have you in the way of technology. If it doesn't fit in your budget, and maybe your organizations are allocating budget in different places. So, paper may be okay for today. And maybe what can happen is you build a digital maturity map, or you work with your teams and think about when next year comes in your budgeting cycles, what you may be able to do, and you'll make better decisions about investment in technology that meet your needs. But your jobs, I deeply understand, are in patient care. And if paper is where you are today and you're doing a good job, I'm sure your referral sources have that in mind. And I encourage you to reach out and ensure that, those lines of communication are open about referrals and business opportunity growth, because people are trying to move digitally purposefully, but at a pace that doesn't undermine quality care and patient safety.
Awesome. Well, that is a perfect ending point. We don't have any more time for questions, but those were some great ones. So thank you so much to the audience for those. We hope you have all enjoyed this webinar. This session will be available shortly at mcknights.com/120820 webinar. We'd like to give a very special thanks to presenters Brenda Hopkins and Michelle Darnell. And of course, we want to thank you, our listeners. You've been a very important part of our success today. Thank you very much for tuning into this McKnight's webinar. This is Liza Berger for McKnight's.